Yeah, Paul, feel free to chip in.
Okay, morning. Thanks everybody. Yeah, thanks everybody. Just a quick thing. Whilst I remember, we did book lunch. I didn't remember that we'd booked lunch, but there is lunch. So those of you who are not shooting off, you can have food before you go. I've asked them to get it ready for 12 o'clock. I think we'll be finished by 12, maybe a little bit earlier. We'll see how we go. Couple of other thank yous. I'd like to thank the AV team who've done an amazing job. I surprised them yesterday by having a speaker come through on Teams, and they handled that absolutely amazingly. So thank you very much. And I just want to thank Andrea as well. Andrea has helped with the HEPC meeting before, but isn't in that role anymore, but has quietly been helping me out over the last 2 days. So thank you, Andrea. Thank you. Okay, so last couple of talks of the day, and first up is Reese Oakley. Reese is a pharmacist in Cardiff who specialises in bloodborne viruses, does hepatitis C and HIV. But although he's based in Cardiff, he's done an amazing amount of work on a national level. He sorts out the HEPC guidelines, the treatment guidelines. He's put them onto Microguide, it's called now, isn't it? Microguide. And he does an awful amount of work on a national level within his role, which is actually Cardiff and Vale. So thanks to Reese for everything he does, and over to you for some updates. Oh, sorry. Someone may have left a coat in the Philharmonic, or someone may have picked up a coat that was on a chair and brought it home with them. But if anyone recognised this, we have it. Any takers? No, okay.
Okay, thanks everyone. Yeah, so as Brendan said, I'm Reece. I'm one of the pharmacists in Cardiff, and I was just going to give a bit of an update on hepatitis C treatment. I acknowledge that some of you in the room are going to be very skilled at treating hepatitis C, but I think, you know, we've seen lots of presentations from lots of different healthcare professionals, and not everyone did get involved in the treatment aspect of things. I think, you know, some of the presentations also highlighted maybe where some patients weren't being treated, and we probably do need to acknowledge that we need to expand the pool of people who can treat hepatitis C, because I suppose this is an easy job for me today to talk about the treatment because it is pretty straightforward. And as Brendan said, earlier on, he said that most of the time things are very easy to solve, but sometimes some things aren't. And I think that's probably similar for hepatitis C. Most cases it's very simple, but there are some other cases where it isn't as straightforward. Please, by all means, I'm happy for people to jump in, interject as well, because I'm aware, although I have helped bring some of these guidance up to date, I have had some help from other pharmacists across Wales as well more recently. So please feel free, if there's other bits that I've missed, to just jump in. So again, we're all used to this, why we want to treat hepatitis C. So we want to treat it to improve or regress the necroinflammation. We want to reduce the risk of liver cancer and liver-related mortality, reduce all-cause mortality, and then treatment as prevention. And I think, there's been some interesting points picked up, which I'll go through, and maybe some common scenarios that we often see, which I'm sure lots of you also see. And it poses us dilemmas in terms of treatment. And obviously treatment as prevention. And I think, as we're all upskilling or upscaling the amount of testing that we're doing, we're obviously treating more, but we're also seeing people who get reinfected over and over again. So we've got one gentleman who's in his 40s in Cardiff, and he's had 9 different hepatitis C acquisitions, and they have all been distinct. Obviously the prevention strategies aren't working there. But also, again, looking back to what Nicola did in her case in terms of that, trying to identify your networks is really important. And maybe that's something that we need to do on some of our cases that just constantly keep getting reinfected. So again, there's been massive advancements in the treatment, and some people have probably come into hepatitis C at different points. Some people will have been here for a lot longer than other individuals. So I thought I'd strip it back a little bit just to make sure that we're covering everything. So essentially, we use combination treatments. You really need 2 active drugs to treat hepatitis C. And as I said, and we've all acknowledged, treatments are very well tolerated. But I think, like Ryan said yesterday in his presentation, there are still some people out there who still think of the old treatments. So I think, if we can make sure that everyone is aware of the treatments, whether that's the testing teams to continue to talk about treatments and provide information, I think that's all beneficial for the patient. And obviously, as we said, they are very, very effective, upwards of 95%. And in terms of what treatments we use, they target different parts of the virus and in terms of its replication cycle. And these are kind of the 3 main groups of drugs that we use. And you can see we've got the NS3 inhibitors, the suffix Previa makes them very easy to understand which class of drug, which class that drug is in. Then we've got the NS5A inhibitors, which end in Asvia. And then obviously we've got our NS5B inhibitors as well. Most of these are available in obviously a single tablet or in multiple tablets. So trying to make it as simple as possible for the patients. So as I said earlier, treatment is very, very straightforward for the majority of individuals, and most of us will probably pick one of 2 regimens in reality. That will obviously be either a sofosbuvir velpatasvir option or a glecaprevir pibrentasvir option. By the way, these aren't just there are other options that are available, but I think, in terms of what's applicable to the audience, these are probably the regimens that are used most. Obviously, pan-genotypic, obviously, there are different genotypes, or what we call different strains, which have different genetic makeups. And obviously, this is why we've been able to use simplified treatment regimens, because we have agents which do cover all types of genotypes. And then in terms of, looking at Epclusa number 1 there, again, this isn't in any order of preference, by the way. We got 1 tablet once a day, typically for a 12-week duration. This is important. We'll come on to that in terms of what factors you might consider in terms of when you're picking a certain regimen. And then we've got Mavorite again, or glecaprevir pibrentasvir, which is a pan-genotypic, 3 tablets daily with food, and generally for an 8-week duration. And then we've got our Harvoni product over there, sofosbuvir ledipasvir, which is only for certain genotypes. So a bit more testing needed if you're going to pick that one. I thought we can't forget about the children. I know Jess is here, and we do treat children for hepatitis C, and there are licensed products now available for children upwards of 3 years of age with different formulations available. So hopefully, if this works, I'm going to try and just show you how we access the All Wales guidance. So as Brendan said earlier, we've now put it onto microguide. So each health board has a microguide available to them, and the All Wales guidance can be picked up through that. So I just thought, this is the best place to find the guidance. This is obviously rubbish. It can't, obviously Word documents were sent around previously, so it's version controlled. It's the most up to date, but there are a few further updates that we need to do to the guidance, and I'll just touch upon them as I go through. Sorry, you're right if I close that. So we heard all about the different settings that people are being treated in, and we do have some typical guidance available for different settings that people present in. So we do have our prison guidance that we did develop depending on what testing strategies you are using. These are better, by the way, if you've got it on your app as a phone app, so you can get this easily on an app, and it does fit more nicely onto the screen rather than what you see here. So depending on what strategies you're using and what treatment options you're going to use and what setting you're treating patients in will depend on the guidelines you follow. I thought there's a few things that we'd pick up here in terms of, I know Brendan's going to talk about it later on, in terms of dry blood spot testing for checking if people have achieved an SVR. Obviously the gold standard would be to do ideally a venous sample or maybe a capillary sample, which have got lower limits of detection available. But we are consistent with the EASL guidance in terms of being able to do dry blood spot testing for SVRs, where they encourage its use if it's not available or it's not financially available in countries. So we can use it as an option. Then we do have the community guidelines, and Liz touched on this in terms of her use. Obviously, these are guidance. People may adapt it slightly to what they prefer. But essentially, as we've all said before, there's very little you need to know about or very little investigations that you need to do prior to starting someone on treatment. And again, this just shows all we're looking at is, a dry blood spot test or any other test that confirms hepatitis C, a drug-drug interaction check, and then a assessment for liver disease, and even in this area of the guidance, there is, ideally you'd do that via biomarker or FibroScan, but you can do a visual look as well, because essentially, there's a high probability of success from using pangenotypic regimens. So that's the different pathways, but I thought I'd just go into the guidance section as well, just to show you what is available here. So resistance testing, I won't touch too much on that. Brendan's going to discuss some resistance cases later on. But essentially, if you go to the treatment recommendations, we essentially break that down into the different genotypes available. So we can then separate it down into different stages of their liver disease, whether they're cirrhotic, non-cirrhotic, and whether they're decompensated or not. And there is different, that's available for all of the genotypes. And then additionally, we have a section for virtual panel. So individuals that where some extra thought might be required. So here's some examples of some reasons why you might refer to someone to the virtual panel. We will set up a Microsoft form, which is due soon, and we'll put a link and embed it into this section of microguide so that people can a test apparently. So I'll So yeah, so there will be a form or link or a QR code in here for referral to virtual panel. This will just make sure that all the information that we need to make a assessment on the appropriate treatment option for patients is done swiftly, and there's no back and forth. So that will appear there. In terms of other updates, in terms of the guidance, again, one of the updates to the panel recommendation will be to put Sapatier as a option only after discussion with the panel, and not to be used freely due to financial reasons. And then we're going to update the guidance in terms of Maveret's use across all patients with compensated cirrhosis to include 8 weeks for all those who are treatment naive with compensated cirrhosis. So that's essentially where you find the guidelines. I think that's probably that will be the best place to look when you want to access them. I'll just go back to this. Oh. So just to go through then factors that you might consider when you're picking a regimen. As I said, very, very simple. Have they got virus? Is there any drug interactions? You can then, and is there any evidence of liver disease? No, you can crack on and use one of your pangenotypic regimens, which would be, as I said, Epclusa or Maveret. And then these are some of the other factors that you may want to consider. It is a fine balance between getting patients onto treatment quickly, but in some cases you may want to wait to put people onto treatment. And these are some of the factors that I'll go through in terms of why you might want to think about these. So cirrhosis, genotype, tablet burden, etc. So I'll start with, obviously I'm a pharmacist, I'll start with the drug-drug interaction stuff. What I would say is that there is very few drug-drug interactions now between most of the directly acting antivirals. There are still some very significant ones that we need to be mindful of. I am going to, just for those who may not have seen the Liverpool website, I will go through it. For those of us, or those of us who are managing it probably have seen it, but you don't need a pharmacist to run that drug-drug interaction check. But I'll tell you when you might want to look for some advice regarding it. So I just put up a little case here that we in Cardiff were referred from Powys. So it was from one of the clinicians in Shrewsbury who asked us to prescribe some treatment, and within that, within the transfer letters that we received, there was something about the patient having amiodarone-induced thyrotoxicosis, and I don't know whether anyone would think any differently about what treatment options you're going to give, or whether there'd be any further information you would want to establish prior to starting someone on treatment. I don't know if anyone wants to give a shout what you'd be worried about or potentially worried about. Well, amiodarone is a drug, but so in this case, we referred it, and so it didn't tell us when the individual was on amiodarone. So amiodarone can't be used with a sofosbuvir-based regimen, and amiodarone has a very long half-life, so it will linger in the body for a long period of time. So actually, on further questioning, it turned out that it was 3 months prior that they stopped the amiodarone. It's likely to still be in there. So there have been deaths related to amiodarone being co-administered with a sofosbuvir-based regimen from heart block. So we didn't give a sofosbuvir-based regimen in this case, and we gave Maveret. So sometimes, as I said, you need to take a proper drug history, which includes like over-the-counter, herbal, etc. In some occasions, it might be useful to ask about recently stopped, but most of the time that's not, you won't need to do that. But this case, I think it just highlighted that wasn't very forthcoming. That information was just embedded within the letters. So in terms of the drug-drug interaction, so for those who don't do this, it is very, very easy to check whether a drug will or will not interact with treatments. These websites are updated by individuals, pharmacologists, physicians, pharmacists. So it's the most appropriate place to check for drug interactions. But if I just show you, if I can spell. So it operates a traffic light system. As I said, you don't need a pharmacist to do this, okay? As long as everything is green. So green is very straightforward. Obviously, you don't need to do anything. It's the amber and the red ones that you need to worry about, and you can click on these to get further information. But, you know, like say Louise and Ryan, you know, I'd be happy for you guys to like do this type of stuff to check that patients that there's no interactions between patients' treatments as long as there's no amber or red. It is a very simple tool to assess for the appropriate treatment options and for drug-drug interactions. And then genotype. So again, you know, I thought I'd put in a case that we got kind of given to us in terms of it was a patient who was picked up through our inclusion health service, a recent migrant, 16-year-old who was from Sudan, had some previous treatment for hepatitis C, and was genotype 4. What would you guys do in that instance? Those of you who manage and treat hepatitis C. Yeah, so it's worth remembering that lots of the studies that were done weren't done in countries where odd genotypes may prevail. Like Nicola said yesterday, you know, when she said it was no surprise that one of her patients was genotype 1A. You know, most of the distribution of genotypes in the UK is going to be 1 or 3, and that's very straightforward. But there are some odd genotypes out there where don't have the same success rates as seen in the trials. Okay, so typically we're talking about genotypes which aren't 1A or 1B, genotypes which aren't 2A or 2B, genotypes which aren't 3A, and then any genotype 4, 5, or 6. You know, there are cases where some of the treatments just won't work. But as I said before, you know, it is a fine balance between getting patients onto treatment, losing them, versus giving them the most optimum treatment regimen available. But typically, yeah, we would resistance test these individuals. And I think it's probably worth noting at this stage, you know, if you are thinking about potential resistance testing and genotyping, rather than sending it to the lab to do a genotype and then sending it on to do resistance, you might just want to send it straight for resistance to get your genotype and resistance report back in one, rather than delaying the therapy. And then in terms of cirrhosis, I didn't see Baz's presentation yesterday, but again, you know, it's a fine balance. What we do know is people with cirrhosis may have less chance of achieving a cure from their hepatitis C, whether that's through, you know, less drug penetration through a scarred liver, areas where the virus, you know, can hide out and not be exposed to treatment options. As I said, again, you know, the assessments for cirrhosis are quite straightforward with your biomarkers, which are very good at identifying no fibrosis or cirrhosis, but not so good for those intermediate areas. And then probably as Bad's picked up yesterday, in terms of your protease inhibitors, it's worth remembering that these are not recommended in people who've got advanced liver disease. Again, though, it might be the only option that's available. So it is, and we do consider it in patients with advanced disease where we have no other option. But thinking about our rapid pathways, you know, people who've got advanced disease probably wouldn't be people you'd be putting through your rapid pathways in terms of rapid access to treatment. And just while we're talking about that, probably hepatitis B is another area where we probably wouldn't put someone through a rapid access treatment protocol because of the risk of reactivation. You probably could once you put them on some therapy. So the reason you worry about protease inhibitors in liver disease is obviously they are their levels are massively increased, and there's an increased risk of decompensation. And it's also worth remembering that you may want to look to see whether patients are prior decompensated. So they may be compensated now, but if there's any evidence of past decompensation, you may want to consider avoiding a protease inhibitor. But as I said, if it's the only option you've got, that's the only, you may have to consider it. But I think you'd want to be discussing that with your clinical teams. In terms of food, you know, as we said, you know, lots of these patients don't have access to food. Mavorite has to be taken with food for it to really be as effective as we see in the studies. So if people haven't got access to that, and that's something, you know, that we do discuss with patients. And then tablet burden and adherence. And, you know, this is really important. You know, what we do know is if patients comply with treatment, we get very good success rates of treatment. What we don't know that well is what the optimal level of adherence is that patients need to have. But I think the message is very clear. We need to support compliance as much as possible. There are studies that have looked at different ranges of compliance, and it does look relatively good, but I would not encourage you to discuss that with patients. And again, there's some bits you need to remember about the studies. They are looking at a specific drug in some cases, so which will not be, you will not be able to extrapolate that to some of the other agents you were using. And then in terms of adherence, you know, we need to support adherence as much as possible. I think, you know, certainly my experience from the HEPC Trust, you know, who are going around like moving places, getting these medicines to people, whether they've gone to hospital or wherever, you know, and that's vitally important to keep these patients on treatment. And I think, you know, a question we probably get asked a lot is what if someone's missed a certain amount of treatment, do we restart or do we not restart? You know, and I think there's probably a lot of factors that need to be considered regarding that. I think, you know, looking at some of the information that we do have available, you know, obviously early discontinuations, you know, seem to be at a higher risk of failure. So we do need to make sure we support adherence. And even when we are thinking we've got patients in supported environments, you know, adherence is still doesn't work out as we would expect. And there's obviously lots of different mechanisms which we can help to support adherence. And I suppose I was just going to say, we do still have available, certainly for the treatment failure patients, a video observed therapy. Now, several years ago, someone came to present to us about video observed therapy usage in TB. So we still have it available as an option for patients who fail first line therapy with hepatitis C. Now, this has been approved through all the governance, all the data protection stuff from Cardiff, so it is applicable to all of Wales. So anyone can reach out if they want any support with some video observed therapy. And again, so in terms of pregnancy, there are small studies that look at treatment of hepatitis C in pregnancy, and so far there doesn't seem to be any signals that the drugs cause any malformations to the fetus or any adverse outcomes. However, these are very, very small studies, so we still don't recommend treatment in pregnancy at the moment, but we need to remember it, you know, is there a risk of conceiving whilst you're on treatment? And again, I think, you know, it might have been alluded to yesterday about previous failures, as we struggle sometimes to get the SVRs. So you get individuals who have had some treatment. We might see them a year after they finished their treatment and they're positive, but we never got an SVR. And it's then distinguishing between, is this a reinfection or is this a treatment failure? So obviously you need to balance that. Sometimes it's quite straightforward. And I suppose if you were able to say that someone was fully compliant with their therapy, and there was clear risks that they have likely reinfected, whether that's through speaking to them, whether there's confirmation from, you know, a massive spike in their ALT, you may be a bit more comfortable in saying that this is a reinfection rather than a treatment failure, and rather than going down that line of repeating your genotype, getting a resistance test. Obviously, the optimum would probably be to do that. But again, it's a fine balance between treating people quickly and not losing them. But ultimately, also what we don't want to do is to drive transmission of resistant virus. So I suppose that is a whistle-stop tour in terms of our treatment. As I said, on the whole, it's very straightforward. You're going to give people a pan-genotypic regimen, and people are going to do absolutely fine, and they're going to clear their hepatitis C. But on other occasions, there are other factors that you might want to consider when you are picking a regimen. But there is lots of choice out there.
Any questions for Reese? There was a problem with one of the anti-epileptic drugs, wasn't there, in terms of treatment options? Has that changed?
So yeah, so there used to be certainly when you go on the Liverpool website, it used to be red for lots of the anti-epileptic drugs, but actually now there is some studies that show actually you treating them and you worry about your enzyme inducers, so your phenytoins, your carbamazepine. It's now, if there is no other option, you can treat them with the DAAs with probably close monitoring of their viral load. So you normally, though, you can get away with changing the anti-epileptic, but for the patient, that might be fraught with issues that they don't want to consider.
Yeah.
But you can potentially treat them now.
Success rates are pretty
seem to be the same as people who aren't on anti-epileptic drugs.
Yeah, okay. So they're not necessarily that common, but they're important. So it's good to know that. And video observed therapy, we haven't used it very much, but we do have it as an option, don't we? So if you've got anyone out there that needs that, Reese is your man to go to. And yeah, if you need any other questions, go to him. I didn't know that amiodarone. So 5 half-lives, isn't it, for a drug to be out of the system?
Yeah.
I just looked it up. Amiodarone is about 60 days.
Yeah, it's huge.
So you're talking, well, I'll let you do the math.
Yeah, you could do it with
2 months times 5, 10 months, isn't it? About 10 months.
Yeah, just under
possibly up to 2 years. Yeah.
Yeah.
Excellent.
Thanks
Okay, thanks a lot. Okay, so I'm just going to finish up with the last talks of the day. I can find them. And someone asked me to talk. These talks that we're giving now are things that people asked us to talk about. So one of them was resistance testing, and I know, or management of resistance, and I know it's slightly a controversial issue. And I just need to find it. That's it. Yeah, okay, so I'm going to talk about retreatment, and I know it is a bit of a controversial issue, and it's slightly controversial, partly my own fault, or it's on me, shall we say, because generally, I think within England, it's considered that retreatment is a straightforward issue. You just give Vasevi, and you don't really have to think about it any more than that. And there is an argument for that, because that is essentially the only drug that is available that's proven to work as a retreatment option. It's very easy to take. It's 1 tablet once a day. And we could make it as simple as that. I don't think that is the appropriate way to manage patients who have failed previous treatment courses. There's a perception that resistance is never going to be a problem, and I think that perception is wrong. There's a very famous quote from the 1950s or 60s or 70s or something about that bacteria are done. We've sorted out infection, and we know that isn't the case. We're facing something of an antibiotic Armageddon. And the one thing that you can be absolutely sure of in infection is that organisms will develop resistance to whatever treatment we're giving. The battle of survival from microbes and viruses and what have you has been going on for generations. In terms of the antibiotics we use, for example, a lot of them are derived from fungi, and fungi use them to kill off bacteria to gain the selective advantage in their environment. So bacteria have been adapting and modifying themselves in order to survive the onslaught of antibiotics long before we started purifying them and giving them to people. And viruses adapt at a much faster rate than bacteria. And I can, I'm a little bit out on a limb because, you know, the perception, like I say, within England is it's simple. We're just going to treat, it's all going to go away. But I'm pretty confident that that is not going to bear out in reality. And what will bear out in reality is that we will have resistance, and we'll have transmitted resistance. And the problem with transmitted resistance, once we get to the point where we've got a virus which is untreatable, which will happen, that has the potential to derail the whole elimination program. So for that reason, when we get onto discussions around retreatment in Wales, we're having a much stricter approach towards it, and we're trying to put everything through a panel. Some of the point of the panel actually is just to be a little bit of a blocker. And the point of the blocker is to get people to stop, think, and say, right, okay, what are we dealing with? What is the resistance pattern? What is the best drug which gives us the best chance of outcome? Is the patient actually ready for treatment? Is the patient a risk to others around them in terms of passing on infection? And it's a bit paradoxical, because if they are a risk of passing on infection, what we don't want to do is generate the super resistant virus in that individual. Slightly paradoxically, we'd rather they have a partially resistant virus that they're spreading, which we can eradicate from the person they're passing it on to, than a fully resistant virus. So that's our position. I come under a reasonable amount of flack about it. I'm not going to change my position. I think I'm right. If I am wrong, you know, we won't know until long after I'm dead, so never mind. So when we talk about reinfection, you know, we have to try and ascertain what the cause of failure is. Okay, so the main causes of failure are reinfection, and this is why obtaining an SVR is so important. And I think we saw in one of the talks yesterday that the HEPC Trust were very keen to try and get SVRs, and I think there was a little bit of a nod towards me, which was we're trying to establish SVRs because Brendan is a right pain in the arse about reinfection, and if we've got an SVR, we know we can retreat and we don't have to go through the panel. Which is, you know, fair enough. And if it drives us towards getting more SVRs, then that's a good outcome as far as I'm concerned. So if you get an SVR, they've cleared, and then you pick up that they've got an infection again, it's likely to be in reinfection, and that helps us a lot because we can retreat them as if it's a first infection. And we can't rely, you know, initially we thought, well, maybe we can rely on genotypes and things like that. But actually, there are certain genotypes which are very common. And so if you're infected with a common genotype to begin with, and you get reinfected, the chances are you're going to be infected with a common genotype again. So having the same genotype as first time doesn't really tell you whether it's a reinfection or a relapse. There is an issue of compliance, obviously, as we know. I think we're sometimes falsely pejorative around, you know, chaotic individuals and whether they comply with treatment or not. And I don't really. Obviously, that is a factor, I suppose, but it's not entirely, you know, the factor. I've got lots of non-chaotic people who are absolutely terrible at compliance. I myself would probably be an awful complier when it comes to treatment. Well, maybe I do have a chaotic lifestyle, actually, so maybe I'm not a good example. But the point being is that you can't judge someone's compliance just by who they are and, you know, how they appear. Compliance is an individual factor, but compliance can be an issue. But I think a lot of our treatment failures actually also perhaps are related to some minor baseline resistance, which when given alongside some minor breaks in compliance can result in treatment failure. And a lot of the time, we don't know why someone's reinfected because we don't have the SVR. So we don't know, is this a relapse or is this a reinfection? Whilst I'm stood here, there's another cause of treatment failure, and that is people never took any of the drug in the first place. And we do see that reasonably commonly. And that's quite an important thing to establish as well, because the good thing about not taking any drug is that they also haven't developed resistance because they haven't been exposed to anything. And you know, that really happens. We've got several cases in Cardiff where we've dispensed drug on at least one occasion, and it looks like they're reinfected, but they've never taken anything, so they can be managed fairly straightforwardly. So what do we advise in terms of managing resistance? Well, reinfection. The first thing is we ask for a resistance test, and a reasonable proportion of our reinfection cases are reasonably straightforward because when we do a resistance test, they don't have any resistance, and then we just manage them as if they were a first-time infection because their chances of a good outcome are very good. We ask that whenever someone writes in, it's a fairly standard reply in lots of ways. It's like, well, why have they failed? Were there issues of compliance first time round? And what assurance have you got this time that compliance is going to be any better than it was last time? Now, I accept that, in the same way that you can't judge whether someone's going to take treatment or not just by who they are or how they look, you really can't judge whether they're going to take it a second time very well. It's very much on them and their motivation. And I saw I think it was one of these meetings, actually, someone talking about motivation. And, motivation is not this like, oh, I'm motivated, and if I'm motivated, I'll be motivated forever. Motivation is like, I wake up in the morning and I'm motivated to go for a run, and then half an hour later, if I haven't gone for a run, I'm not motivated to go for a run, and then half an hour later I might be motivated to go for a run again. And motivation just swings throughout the day, and it changes on a regular basis. So trying to judge someone's motivation for a 3-month treatment course on a one visit is impossible. So there's no way of knowing exactly whether someone's going to be compliant with treatment or not, but we have to do our best to assess that, and we have to do our best to try and support people in their compliance. Ask them questions, around whether they're likely to take treatment, what might have interfered with them taking treatment last time. Is there anything we can put in place to help with that compliance issue, whatever it is, whether it's they tried to take it last thing at night and they were taking it at 9 o'clock and they always fall asleep at 7, these sorts of things. Or is it a food issue? Do they struggle to take it because they're not getting access to regular meals, etc., etc. So we need to try and address compliance issues. We establish a treatment plan, which we can do through the virtual panel. We check drug-drug interactions, and as Reese has demonstrated, he's amazing at that. I didn't know about amiodarone. That's a new fact for me today, and I wouldn't have even considered that a useful thing for me. We have to be careful about antacids. I was going to ask you, Reese, actually. So we talked about food compliance with Mavaret, which will generally be an issue with any of our 3 treatment options. So the main treatment options for retreatment are either Basevi, which is sofosbuvir, which is an NS5B, velpatasvir, which is an NS5A, and the other one, voxilatravir, which is a protease inhibitor, or sofosbuvir and Mavaret, which also contains an NS5B, an NS5A, and a protease inhibitor. And so they will require food in general. What's that feeling about Epclusa and food? Is it's still preferred, isn't it, or is it not really? Yeah, so that's the point I was trying to make. So with Epclusa, you don't have to take it with food because the absorption is good enough that you can take it without food, but you do get higher exposure levels with food. So there's sort of no harm in taking it with food. If anything, it might be beneficial. And in a retreatment situation, that might be something we want anyway. one of the issues around reinfection or a new infection is what we discussed yesterday about trying to treat a network of individuals. Because there are two things actually. One thing I want to say earlier: if someone doesn't take treatment first time, there's a real sense among us that we want to treat people. We do a great job of treating people, and we want to get people on treatment. But it's always worth bearing in mind that if someone doesn't take the treatment, they're not going to get better. So giving treatment to people who are not going to take it, you're not doing anybody any favors, actually. So that's why trying to sort out compliance is such an important factor. And then if you treat someone, but they're still injecting with other people who haven't been treated, Paul showed us a slide earlier of a network of individuals where one individual is not getting treated. And if they're sharing or they're at risk of sharing, then you're not really going to get very far by eradicating it in that individual, because it's just going to come back. So this is something that we need to get better at, I think, trying to treat a network of individuals, because we can eliminate it, not just in the individual, but we can prevent it coming back. So I've already covered this. So the retreatment options is quite simple, really, in terms of drug choice, that we've only got two options, which is Vasevi or Mavret and Sofosbuvir. We have actually got slightly more options, but these are the main two that we're going to be going to. The duration is around 12 weeks, but we talked a bit about yesterday the issue of patients with cirrhosis, and particularly if they've got decompensated cirrhosis. And it's in the product literature that you can't really use a protease inhibitor in people who have decompensated. We saw yesterday a case where we did use a protease inhibitor in someone who's decompensated. The reason you can't use it is because there is a risk of decompensation with protease inhibitors. But as Baz showed us yesterday, you've got to balance whether that risk of decompensation is worth taking, because if someone's got decompensated cirrhosis or had decompensated cirrhosis, without treatment, they are going to decompensate. The liver disease is going to progress, and then they're going to decompensate. By giving them treatment, the risk you run is bringing that decompensation forward. But by not giving them any treatment, you're absolutely certain that they are going to decompensate at some point. Whereas if you can treat and eradicate, we saw also yesterday from Tom, thank you, from Tom, that the liver can regenerate, and you can buy someone quite a lot of time just by eradicating one of the insults. So that has to be factored in. Now, so there is options in terms of Epclusa, and giving it for longer or giving it with ribavirin. In my experience, which is very limited, I have to be honest, because fortunately we don't have very many resistance cases, so everybody's got fairly limited experience, which is a good thing because it demonstrates how effective the treatments are. But in the few times we've tried Epclusa in someone who's got resistance or Epclusa resistance, it just doesn't really work, actually. And yesterday, Baz presented a case of someone who we did give a protease inhibitor to with decompensated cirrhosis. Around the same time, there was another individual, very similar infection, very similar treatment history, also had decompensated cirrhosis. The one we treated had Child-Pugh B. The individual we didn't treat had Child-Pugh C. I wanted to treat them, actually, but nobody would agree with me. No, it's one in Cardiff, yeah. We spoke to the Birmingham and the transplant centre, and they were like, very much, no, you can't do that. And we gave him an extended course of Epclusa and ribavirin, didn't work. And I don't know, I think if we had treated him, probably he would have decompensated and died, but we didn't treat him and he decompensated and died. So back to that same point, that if someone's got nothing, then they've got nothing to lose. Oh man, I have to be honest, I didn't finish this talk. I was under quite a lot of pressure towards the end. I think the main thing is it works. and there is some trial data to show that it works. But I suppose the other thing to say is it doesn't work in everybody, and there are adverse factors beyond just the medication and its effect on the virus, which Reese has already alluded to, which is things like cirrhosis, and why it doesn't work in cirrhosis. We're not entirely clear, but it might be that there's not such good blood supply, and maybe the drug doesn't get into the parts of the liver at the same level as it does in people who are non-cirrhotic. Going back to that point I made earlier about, well, maybe we do want to give it with food, even though it doesn't have to be given with food in certain circumstances, because we want to get higher exposure, try and get more drug into areas which are hard to reach. Hepatocellular carcinoma, that seems to be another area where potentially the virus can persist. So we've seen that a few times where seemingly sensitive virus which should respond, but we get relapses in that setting. There's not very much data around our alternative option, which is hang on. Yeah, I don't worry about that. Yeah, sorry. There's very limited data about relapse after giving Vasevi, but there is a potential rescue using Mavorep plus sofosbuvir with ribavirin for extended duration. And the SVR rate was 81%, which, I mean, in any other condition, you'd take 81%, I think. But, you know, we got so used to treatment success rates of around 95%. And when we say 95%, actually, we really mean around 100% in most individuals. The lack of response is generally in people where there's compliance issues or other adverse factors. So if we pick someone up early, again, going back to what we were talking about yesterday, diagnosing people early, if you pick someone up early, they haven't got any adverse factors, they haven't got progression of their liver disease, not only is it beneficial in terms of preventing them getting ill, but your chances of success are huge with early treatment. And the other problem with 81% is, going back to what I said at the beginning, at some point, mega-resistant virus is going to become a problem for us. And the problem with 81%, that means 1 in 5 people, it's not very many at the moment, but 1 in 5 people who fail sofosbuvir, valpattizivir, foxolaprevir, who then go on to fail Mavorep plus sofosbuvir plus ribavirin, have probably got pretty resistant virus, which is not going to be easy to treat, and that's the problem. Okay, I've covered all that. Okay, I've got some cases just to go through to demonstrate some of the points. Because I didn't finish writing it, I didn't really put them in any logical order, but I'll try and hopefully they'll flow in some way or other, but I'll try and pick out the important things. So this is a very interesting case. It's a 43-year-old factory worker from Lithuania who's been resident in Wales for 12 years and had genotype 3 with about 3 million independent units per ml virus at baseline. Low virus score, so not cirrhotic, should be relatively straightforward. Was treated with Mavorep. I'm not quite sure. Do you know why we went for Mavorep? It wasn't us actually, but I can't remember the factor that meant Mavorep was used first off, but that's what they were given. Seemingly had a good response initially. Week 4 PCR is less than 12. End of treatment it's 12, and we know historically that we don't really know what 12 means at that point, because we had quite a few, particularly very early on, that they seemed to have a bit of virus at the end, but then it went away. I never really quite understood that, but it doesn't necessarily mean treatment failure, although you'd rather it was not detected. But when they came for SVR12, it was back at 3 million. So I did a resistance test, and they were resistant to glecaprevir, which is what they would have received as part of their Mavorep, but they were also resistant to all the NS5A inhibitors, and susceptible to sofosbuvir. Now, there's one thing to say about susceptibility to sofosbuvir. So sofosbuvir is a bit of a sort of amazing drug, because development of resistance to to sofosbuvir is really difficult, and you hardly ever see it in a resistance test. But it's possible that it does happen on treatment, but it's so bad for the virus that even if it does happen on treatment, once you stop treatment, it just reverts back to the susceptible virus, because it's too much of a fitness cost basically to run that resistance change. But another factor around that is if someone's had sofosbuvir in the past, there's just a little bit in the back of my mind as, okay, well, we don't detect any resistance, but it's possible that there is a virus there that is perhaps less susceptible to sofosbuvir than another virus. So that's always in the back of my mind. What on earth has happened here? That's out of. Oh, did we go back to the? Yes, yeah, that right. I remember now. We went back to the initial virus, okay. And this is something else I was alluding to, that some of treatment failure is probably related to baseline resistance. Now, we don't do baseline resistance testing. I think the HEPC trust would string me up if I started suggesting that. And the reason we don't do it is because it's relatively rare, and even when it is present, a lot of people will clear the virus regardless. But at the same time, we also know it's important because, in the people who fail, when we look back, there's a reasonable chance that they had a bit of baseline resistance, which was a factor which perhaps with some suboptimal compliance might have driven them, or even with optimal compliance will have resulted in treatment failure. And that's what we have here. So this person was given Mavorite, but actually they were resistant to the NS5A component. So that means they were only getting a protease inhibitor single agent, and we know that single agent isn't enough. And what happens when you give a partially resistant virus a single agent? Well, they develop resistance to the protease inhibitor. So that's what's happened here. Started with resistance to this class, treated with this drug on its own, essentially, because the drug from this class isn't having any activity, and they develop resistance to that one. Anyway, happily, retreated with Vasevi, 12 weeks, and achieves SVR, which is interesting. Now, the patient is originally from Lithuania. Previous drug use was 25 years ago, had a history of jaundice at the time of injecting. So the point here is that this resistant virus that they started with was just a natural resistant virus. It's got nothing to do with drug exposure, picked up 25 years ago. And those viruses are circulating within the population, which is why, again, resistance, I think, will become a problem for us in the long term. So case 2, someone who took 4 weeks of Mavorite. Yeah, we've seen this, don't we? He was actually keen to take treatment, but then someone decided not to give him the rest of his treatment, even though he told them that he hadn't finished, but they didn't believe him. Another sort of bugbear or frustration of mine, when people just don't listen to what people are telling them. So, if someone's telling you something, at least have the courtesy to listen and check it out rather than think you know best. Anyway, he really wanted to be retreated, and a resistance test was carried out, and there was no resistance. So we just treated him, and he got better. Oh, man, what is this? Yeah, there we are. We retreated him. He got better. So there's another one. Hep C, cirrhosis, hepatocellular carcinoma. Yeah, so this is a really complicated case, actually, another one that we've got referred to us. And what you'll see from this is this patient is multiply comorbid, and risk of treatment is quite significant. So they've got hepatocellular carcinoma, they've had lung cancer, they've got ischemic heart disease, peripheral vascular disease, aortic stenosis, psoriasis, and their FibroScan score is 62. So they've at least got cirrhosis, and they may well have decompensated cirrhosis. And they'd had treatment with 12 weeks of Harvoni, but at the point of trying to get their SVR, they still had genotype 1A. Now, their viral load is quite low, but that's what you might expect in someone with cirrhosis, because they haven't actually got that many liver cells. So even though it's relatively low, it's probably a factor of the state of their liver rather than the fact that the virus isn't replicating. He's fully compliant, he's elderly, lives with his son, and he has no risks regarding reinfection and no risks in terms of passing on the infection. And that's quite important from my perspective, because if he's not compliant with his next course of treatment, the only person who loses out is him, and there isn't a risk to the wider population. So, we'd have a much lower threshold in this case for just saying, well, you might as well give him some treatment and see how he gets on. This is just to show, actually, I probably should have done this case earlier on, but when you get a resistance report, in some ways it looks quite complicated, because you get reports like this, so that there's no resistance associated substitutions, and then they give you a long list of letters and numbers to tell you that the virus isn't quite the same as the gold standard virus that they hold. Okay, so there are changes in this virus, just not that any confer resistance to the drugs on that. You can see that the patient's got these resistance markers. Phase, and then again they give you a long list of other things which are different, the baseline virus that they hold, but seemingly don't confer any resistance. And there's another thing in the report which you can just ignore, which is it tells you the percentage. So this virus, it should be an M at 0.28, but when they checked the virus, it was either an M, an A, or a T. And then they give you percentage. 56% of the virus that they saw was an M, 27% was an A, and 15% was a T. But you can ignore all of that, because if the T is the resistant bit, when you give the drug, the M part will just disappear and the T part will replicate. So, it's quite interesting, I suppose, but you can ignore it. And actually, all you have to really read is this bit. Is it susceptible? Is it resistant? And it's quite straightforward then. So the treatment options for this gentleman were, as we've discussed, sofosbuvir and Mavorette with slightly higher pill burden, 3 tablets once a day. For Sevi, you could give Epclusa and ribavirin for 24 weeks. This patient's got a problem because they've likely got at least Child-Pugh A, but probably with that level of FibroScan, they're either close to decompensation or they've decompensated in the past. So protease inhibitors are likely to be a problem. But you've also got, combined with that there's an elderly gentleman with lots of comorbidity. And I don't think this person's been treated, have they? We don't have any record of them being treated. So perhaps it was decided that treatment wasn't in his best interests. Okay. Yeah, so this is another familiar story. Genotype 3, had Mavorette in prison, was actually given the full course, which is good, because we heard yesterday that sometimes people go to court and then they're whisked off back into society and they leave without having their medication. But on this occasion, we've done what we're supposed to have done, given him the treatment. He can't remember whether he took the medication or not. The person who sent in the request for a review thinks that he probably didn't. Low FibroScan score. And the question here was, well, we've sent off a resistance test, but we're under a bit of time pressure because he's due for release in the next couple of weeks. And the question for us is essentially, would you treat him? Now, the problem is we know that his compliance is quite good whilst he's in prison, but we also knew that he wasn't going to be in prison for long enough to get a full treatment course. So essentially we said, no, don't treat him. Let's get the resistance test. Let's work out what the best drug is for him. Let's try and treat him in an environment where we're confident he's going to complete treatment. That might be when, it's a terrible thing to say, but it might be when he comes back into prison. And to get on a soapbox a little bit, but I think it's just terrible that this idea that it's a revolving door and people are coming in and out. That there has to be something wrong with the prison system if we're just readmitting the same people over and over again. But anyway, I won't get on that. So, well, I've just got on it, but I'll get off it quickly. Yeah, so but he could be back in, and I suppose we could get our treatment plan ready for that occasion. And I'm talking like I do a lot of this, but Reese does most of it these days. Hats off again to Reese, because he's doing this on a national level again, although he's employed through Cardiff and Vale. So thanks for that. Yeah, the short answer was we said wait. I'm not going to do case law because I'm getting bored of my own voice. Is there anything particularly in? I don't know. Bored of that. Okay, so there was one other thing I was asked to talk about, which is DBST testing. Is that enough? Yeah. Yeah. Yes, that's an interesting question. So theoretically, it's not like HIV where it's archived. So most resistance confers a fitness cost on the virus. So there would be a tendency for the virus to revert back to a susceptible type. But in that Lithuanian case, there was a baseline resistance. So that there must have been not too much of a fitness cost with that baseline resistance because it persisted. So some resistance will persist because the fitness cost is not sufficient to warrant it reverting back. Some resistance will potentially revert back. But again, I always think, okay, well, you gave a drug. There wasn't any resistance to begin with, but the virus developed resistance. And probably if you give the drug again, the same thing will happen because there's probably something about that virus that means it's okay switching to a more resistant form. So theoretically, some resistance might decay, but on the whole, I tend to think, well, once you've got it, you're not. I wouldn't rely on just treating again if I thought there was resistance previously. Any other questions about resistance? Yeah. Yeah, it's not a stupid question. I mean, it's sort of a little bit like what I do. Another part of my job is infection prevention and control. And one of the things we do in infection prevention and control is when we identify someone with a resistant bacteria, we put them in a cubicle, and we put them in a cubicle partly so that people are like, okay, well, there's someone with resistance there. We need to be careful, and we'll do the things that we need to do, like washing our hands and be careful, cleaning toilets and what have you. But the slightly frustrating thing is when we do that, all of the measures that we put in place are the measures that are supposed to be done anyway. And sometimes in that setting, it creates a false impression because, you can think, oh, well, we have to be careful in the cubicle because there's someone and we know that that person has got that resistance problem. So we're going to be careful with that person in the cubicle. But, 2 days ago, that person with the resistance problem was in the bay, and they still had the resistance problem. We just didn't know about it. So the message should really be not, "I'll be careful in the cubicle," which we do want to be. The message should really be careful with everybody, because just because we don't know about it doesn't mean it's not there. So the answer is yes, in a way, we should try and reinforce the importance of not sharing works, not sharing needles, etc., etc. But at the same time, the message should be that should be what we're doing with everybody anyway. And one of the targets we're not quite hitting at the moment is provision of needles. I think it was 300 per person or something. We're not quite hitting that target. And the harm reduction, and I'm not sure Josie might be online, I'm not sure, but the work that all you guys do around harm reduction is huge. It's so much bigger than in many ways what we do around treatment, because we can treat people and we can get them better, and that's really brilliant. But if you stop them getting the infection in the first place, that's 100 times better. To use a football analogy, you know, if you don't concede any goals, you don't have to score so many. And it's the same thing. It's just like prevention, huge, huge, huge. So that has to be a real focus of our work. I've lost where I was going with that. Yeah. Can anyone? 100%, 100%. Yeah. I've just remembered where I was going. There's someone in the room, lost them for a minute, doing a project in Swansea called Spike on a Bike. And there's, you want to say anything about Spike on a Bike?
Outreach, especially the hidden populations of certain diseases in those areas of Devon Powers. And they've had some really, really positive results so far, especially with engaging with communities who don't traditionally use site services. And so, yeah.
Yeah. So hopefully at the next meeting we'll get one of you along to tell us how that's going. And just that's a reminder as well about the postal service, because again, you know, we've got so many modalities now for testing, and the postal service, we're not using it very much. It's quite new, quite novel, but I'd really encourage you to start pushing that, because you know, I imagine there would be a number of people who would quite happily be tested if it was just a case of ordering a kit and it arriving at your door. Okay, the last talk of the day, DBST, is it? Oh, sorry. Yeah, would make a big difference. Yeah, yeah. So a shout out for your service. Yeah, DBST, is it enough for SVR? Yes, there we are. Have a lovely day. Just to expand that very, very briefly, and I'm not going to dwell on it. You know, there's a whole concept of not letting perfection be the enemy of the good, and perfection is the enemy of progress. And again, you know, why I'm so proud to represent all of you is because you do just get out there and you do things, and you don't let barriers get in your way. And not everything is perfect when you start, but it's much better to start and then develop a service than try and get it perfect from the word go. But these are the numbers. So if you do a dry blood spot test, the lower limit of detection of the virus is around 1,000 international units per ml. Now, there will be people with hepatitis C infections lower than that. So when you use a dry blood spot test, you run the risk of missing some people. Now, the reason we say if you're using a dry blood spot test for SVR, we need a 24-week, not a 12-week. So when you do a 12-week SVR, the chances of relapse after that are very low. I think it's less than 1% on a venous blood. But it takes time for the virus to multiply up. So there may be people at week 12 who the virus is just sort of gaining momentum. And well, so we want a longer time period to increase the chances of picking up virus, which is re-establishing itself. Now, it's not to say you can't do an SVR at 12 with a dry blood spot test, because again, sort of back to the same thing, don't let perfection be the enemy of the good. You know, we'd rather have on record that they were negative at week 12 than nothing at all. But we'd want another one at 24 weeks to sort of more firmly establish that we think it's gone. And the reason that's important is because, you know, a lot of our service is going to, it's quite hard to get SVRs, but a lot of our establishment of SVR is going to be through routine dry blood spot testing, just by opportunistic testing. So is it enough? Yes. Is it perfect? No. We now have the Kefid as an option. So Kefid, as Louise showed us and Louise developed, you can take a finger prick of blood, put it into a micro cap, microcap, which is what we use on kids when they're first born, transport that to the lab, and you can get it down to 40 international units per ml. And there are not going to be many people who have got ongoing viral replication who are less than 40. So Kefid is a pretty reliable test, and you can do it without having to do venous blood. So that's an amazing option for us. It's expensive. It's not our go-to, but it is an option, and it's a very important option. And venous blood is no longer 15, it's down to 5. Woohoo! Yeah, 5, and you're not going to get replication below 5. So venous blood is the best whenever you can do that. Kefid is a very good option when if you've got trouble bleeding someone for whatever reason, or you're in an environment where taking blood is difficult. Is dry blood spot testing enough? Yes. The end. Sarah, yeah. Well, if it's enough, it's enough. It doesn't matter. Doesn't matter what circumstance. Okay. No, well, so what you're saying is, historically, someone had hepatitis C. At this point, I don't know whether they've been treated or we think it's natural clearance. Yeah, and then we've got a dry blood spot test at some point in time, which is negative. In general, again, from a perfection perspective, you would never rely on a single negative, because there are all sorts of things that can go wrong, even with a venous blood. You can get blood mix up, something can go wrong in the processing, etc., etc. So ideally, you would want 2 negative tests anyway. So, and then what are we talking about? We're talking about a historical cohort who didn't have access to the treatment options that they did that were available to them. And the potential risk from missing someone is that they're quietly developing cirrhosis. So the end outcome from missing someone is quite significant. So on the whole, I would be saying, I think, okay, significant risk if we don't pick them up. We've got one test which we're saying is enough, but is not perfect. Do we want to try and re-engage that individual? I would say yes, even though the vast majority of them will turn out to be negative. That would be, I think, my position. But if you can't find them, at least we've got the reassurance that they've had one negative dry blood spot test, and the likelihood is that they don't have ongoing replication. Is that okay? I can tell by your face that's not the answer you wanted. Yeah. Yeah. If anyone's lost the key card, probably just hand that in anyway, actually, because they can get another one, I think. Okay, right. That is the end of our meeting. Just once again, thank you all for coming. Thank you much, much more for all the work that you do. Thanks for the collaboration. Just to mention again, it is a massive collaboration. Third sector, NHS Wales, Public Health Wales, people who provide us with testing equipment, and the pharmaceutical company who've given us the medication that enables us to treat people, and Welsh Government in the background doing amazing work actually and helping us move towards elimination. But individually, thank you all ever so much. Thanks for everything that you do for marginalized, vulnerable individuals. And just to remember, we are making a huge difference by treating these individuals and preventing them from developing end-stage liver disease, which is not only beneficial to them, but beneficial to the whole of society, because anyone with that advanced disease, it's expensive to manage, and it takes resource. And when we treat them and we prevent that, that resource can be given to someone else. So somebody who's got nothing to do with hepatitis C, never been anywhere near it, benefits from the work that we're doing, because we're freeing up resource for them for whatever treatment they might need at a later date. Last thing, said it a million times, just thank you. Thank you ever so much. Have a good rest of the day.
Thanks.